Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for January 15th, 2025. Thank you for joining us today, and thank you to the current Osteoarthritis Action Alliance sponsors shown here who help support our work, which includes the monthly Lunch and Learn series. Our presenter today is Dr. Stephen Messier. Dr. Messier is professor and director of the J.B. Snow Biomechanics Laboratory at Wake Forest University. He has been at Wake Forest for 43 years and has 33 years of experience in clinical trials research specifically related to knee osteoarthritis. Currently, Dr. Messier is the principal investigator of the Weight Loss and Exercise for Communities with Arthritis in North Carolina, known as the WECAN trial, and the Osteoarthritis Prevention Trial, also known as TOPS. WECAN is a pragmatic, randomized clinical trial of over 800 older adults with knee osteoarthritis and overweight and obesity that is designed to determine if the diet and exercise intervention implemented in a highly controlled efficacy trial known as the IDEA trial could be successfully implemented in diverse community settings. TOPS is an osteoarthritis prevention study for people at risk for osteoarthritis. These studies are both funded with grants from the National Institute of Arthritis, Musculoskeletal, and Skin Diseases Institute, the Arthritis Foundation, and the CDC. Dr. Messier has received the Lifetime Achievement Award from the Osteoarthritis Research Society International, the Borelli Award from the American Society of Biomechanics for outstanding career accomplishment through exemplary research in biomechanics, and the Career Achievement Award from the American College of Sports Medicine Biomechanics Group. The title of today's presentation is Behavioral Interventions to Manage Obesity and Osteoarthritis. Welcome, Dr. Messier.
Well, thank you, Katie. Before I begin, I would just like to acknowledge our outstanding group of investigators. And as Katie said, our funding sources. Well, it's no secret that obesity has increased over the last decade, with many states reporting between 35 and 40% of all adults are afflicted with obesity. The obesity transition model describes the stages of obesity based on economic development. In stage 1 obesity, populations are poor and often afflicted by war, and therefore obesity rates are low. In stage 2 obesity, the countries are richer, but there's an increasing obesity prevalence. In stage 3 obesity, obesity rises massively at epidemic proportions, and there's actually a plateau in high-income countries. The obesity plateau occurs when obesity has reached its biological limit. That is, nearly all people who are genetically susceptible to gain excessive weight and display behavior patterns related to obesity have become obese already. Obesity rates have plateaued at very high levels in developed countries, but there is a steady, uninterrupted rise in low and middle income countries. So then the universal trend is obesity escalation rather than slowdown, which is driven by steep increases in low and middle income countries. So then the logical conclusion is that the prevalence of obesity-related diseases, including osteoarthritis, will continue to rise and is driven by the strong impact of socioeconomic determinants of health. In 1988, David Felsen suggested that obesity, or as yet unknown factors associated with obesity, cause knee osteoarthritis. For example, women with severe obesity are 17 times more likely to have knee osteoarthritis than women with a normal weight. And if getting osteoarthritis isn't enough to get your attention, how about premature death? As BMI increases above 30, the risk of death increases, in adults ages 25 to 59. So then, as obesity increases, the risk of many diseases increases, including osteoarthritis. But weight loss and physical activity reduce obesity-related morbidity and mortality. In our 8-year follow-up of the ADAPT participants, those that were randomized to weight loss interventions had 50% less mortality than those randomized to non-weight loss interventions. However, there are biological changes that fight attempts to lose weight and keep it off. The body acts in starvation mode, increases feelings of hunger, suppresses satiety, slows metabolic rate, and attempts to defend higher body weights at all costs. So losing weight and keeping it off is not easy. So then, how do we treat knee osteoarthritis? Well, the short answer is not very well. The average time spent living with symptomatic knee osteoarthritis is over 26 years. The first 3 years were a regular cocktail of NSAIDs and braces, followed by 2 to 3 years of injections, usually hyaluronic acid or steroids. And then there's this remarkable period of 12 to 13 years where there's no real definite treatment plan, just using analgesics as necessary. Unfortunately, half these people are just biding their time until they get a knee replacement. So then the question becomes, how do we get people who look and walk like that to look and walk like this? Our mechanistic model shows that weight loss and exercise impact the biomechanical and inflammatory disease pathways, with self-efficacy acting as a mediator that influences pain and function. So intensive weight loss and exercise reduces abnormal stress by decreasing knee joint loads and reduces abnormal physiology by lowering inflammation, resulting in less pain and less disability. So for more than 3 decades, our focus has been on reducing knee pain with diet and exercise. And typically, we get between 10 and 11% weight loss over a period of 18 months with diet and exercise. And this results in a reduction in pain by 51% over that 18 months, compared to only half that improvement with either diet or exercise alone. Also, there's a significant decrease in knee joint compressor forces, or the loads on the knee during walking, with diet and exercise or diet alone, compared to exercise alone. And there's a decrease in inflammation with diet and exercise or diet alone compared to exercise. So we've shown pretty clearly that a 10% weight loss is effective in reducing pain, improving function, decreasing knee joint loads, decreasing inflammation, improving self-efficacy, all these things, all good things happen with a 10% weight reduction. So the next question then becomes, is even more weight loss better? And the answer to that is yes. All right, those who lost greater than 20% of their baseline body weight has significantly less pain and better function than those who lost greater than 10%, greater than 5%, or less than 5% of their baseline body weight. So then, as weight loss increases, pain decreases. Even 3.5 years post-intervention, people in the diet and diet plus exercise group still had significantly less pain than they did at baseline. And they had significantly lower BMI than they did at baseline. But what third-party payers want to know is the intervention cost effective? Well, a quality-adjusted life year is 1 year of perfect health. An ICER is an incremental cost-effectiveness ratio, which is the difference in cost or the willingness to pay divided by the difference in quality adjusted life years gained. Generally, a willingness to pay threshold of $100,000 per quality adjusted life year gained is considered cost effective, and a willingness to pay threshold of $50,000 per quality adjusted life year gained is considered highly cost effective. Our diet and exercise group had an ISR of $34,000 per quality adjusted life year gain. So therefore, diet and exercise is a highly cost-effective intervention. However, there is still no cure for osteoarthritis. So we have now addressed knee osteoarthritis disease prevention, because prevention of osteoarthritis is preferable to treatment. And so we have begun, as Katie said, the osteoarthritis prevention study. And so I have a little podcast that describes the study.
Hey everyone. Ever imagine yourself a few years down the line and your knees are just not cooperating?
Oh, tell me about it.
That's the reality for so many people dealing with osteoarthritis, especially women. But what if there's a way to dodge that whole scenario? That's what we're diving into today, a potential game changer in osteoarthritis prevention.
We often think of osteoarthritis as an inevitable part of aging,
Mm-hmm.
like something you just have to accept. But this study from Wake Forest University suggests we might have more control than we thought.
Right. We're talking about actually preventing osteoarthritis, not just managing the pain after it takes hold. And they're doing it with a massive study called TOPS, the Osteoarthritis Prevention Study, which is exploring the impact of weight loss and exercise on joint health.
And it's a huge undertaking. We're talking $17.1 million in funding, collaboration across multiple universities and organizations, even internationally.
Now, this study focuses specifically on women aged 50 and older who are overweight but don't yet have osteoarthritis. The idea is to catch those early warning signs and see if lifestyle changes can make a real difference.
Which is key because they're looking at prevention. They need participants who are at risk but haven't yet developed the condition to really understand what interventions might head it off.
Okay, so let's unpack exactly how the study works. They have two groups of women, one focused on diet and guided exercise, and the other a healthy living group who receive education and support around overall well-being.
The comparison between those two groups will be incredibly insightful.
And the diet and exercise group has a pretty ambitious goal, aiming for a 10% weight loss in that first year. They're using a calorie-restricted diet, but with the option of using meal replacements.
And it's not just about cutting calories. They're incorporating twice-weekly cardio and strength training sessions as well. It's a comprehensive approach that addresses both diet and exercise.
Now, here's where it gets really interesting. Professor Messier, one of the researchers involved, has done previous work showing that every pound of weight loss equals 4 pounds less stress on your knees. Think about that. It paints a very powerful picture of the impact this could have.
If they can demonstrate that these interventions prevent or delay osteoarthritis, it could change how we approach joint health as we age.
It's not just about the numbers on the scale, though, is it? The study also incorporates those crucial lifestyle factors in the healthy living group.
Absolutely. They're getting together regularly for workshops on things like nutrition, stress management, and even building a stronger support system. It's about empowering participants to make positive changes in all aspects of their lives.
You know, it's one thing to lose weight, it's another to keep it off and maintain those healthy habits long term.
And that's where Professor Mahalko, the study's behavioral psychologist, comes in. Her research is exploring how to best support participants in maintaining their weight loss beyond the study.
That's smart, because we know yo-yo dieting can be tough on the body.
Exactly. This study is taking a holistic approach, considering not just the physical changes, but the psychological and behavioral factors that play a role in maintaining a healthy lifestyle.
Totally. Imagine if they prove that making these lifestyle changes can actually help you avoid this debilitating condition. That's huge. It's about shifting the paradigm from treatment to prevention, from reaction to proactivity. Speaking of the study's design, one thing that struck me is that they're following participants for 4 whole years. That's a pretty significant commitment.
It speaks to the rigor of the research. They're not just looking for quick fixes or temporary changes. They want to understand the long-term impact of these interventions on joint health.
Mhm.
And to do that, you need time.
Right.
You need to track those changes over an extended period.
You know, it's funny, we often hear about the importance of investing in our health, but this study makes that idea so much more concrete. It's like, here's this potential opportunity to invest in your future mobility, your ability to stay active and independent as you age. And it's not just about the physical benefits, is it? This study also highlights the power of support and motivation in making healthy changes last. This whole deep dive into osteoarthritis prevention has me thinking, how much control do we really have over how our bodies age? I mean, this study is suggesting we might have more power than we realize.
That's a powerful takeaway. It challenges the assumption that osteoarthritis is inevitable and suggests that proactive steps might rewrite our future.
Now, that's a thought to leave you with. Thanks for joining us for this deep dive, everyone. Until next time, stay curious.
All right. So we all know, however, that there's a lot of people that would rather just take a pill or take an injection rather than embark on a lifelong journey with diet and exercise. And that brings us, I want to just talk a little bit about all the rage right now, which are GLP-1s or glucagon-like peptides. What are these? This is a hormone that regulates appetite. It slows stomach emptying, increases how full you feel after eating, and triggers insulin release from the pancreas, which essentially prevents more glucose from going into the blood. It was initially designed to lower blood sugar in diabetes type 2 patients, but is now also approved for use in weight management. And it is extremely effective in reducing weight. In general, across a number of studies, the average weight loss over a period of a little bit more than a year is about 15% of baseline body weight, compared to a placebo, which is about 2%. And even a new study came out just this year in New England Journal of Medicine, or should I say last year, 2024, that showed even in people with NIAMS, they get the same weight loss as in previous GLP-1 studies. So it's very effective in reducing weight. However, it comes with a cost. The annual cost of a diet and exercise intervention is about $3,400 compared to GLP-1s or semaglutide, which was $16,200, or tirzepatide, which is $12,700. This is per year. And of course, the big question that people want to know is what happens after I stop the drug? And while the answer is not very encouraging, there's a rapid weight regain with 2/3 of the weight lost regained in 1 year. And nearly all the weight regain is fat mass. So you're fatter than you were before you began the drug treatment. And there's a worsening of cardiometabolic risk factors, such as A1C and systolic blood pressure. So this suggests then that lifelong treatment with GLP-1 will be necessary to maintain your weight loss. In a recent study on GLP-1 that's published in JAMA, 40% of participants had diarrhea, 30% had nausea, and 20% were actually vomiting. So would you rather look or feel like one of them or one of them, eating a healthy diet combined with regular exercise? I think the answer is a no-brainer. Our interventions also are designed to build self-efficacy. What is self-efficacy? It's confidence that you can produce the desired effect. In this case, being able to diet and exercise and maintain that weight loss. We've shown that diet plus exercise significantly increases self-efficacy compared to either intervention alone. So then our interventions increase self-efficacy, which build confidence, resulting in more sustained weight loss. This, however, does not build self-efficacy. So what are the limitations of GLP-1? Well, but there's a loss of lean mass, there's high out-of-pocket costs, the apparent need to maintain treatment for a lifetime, and the absence of a structured psychosocial behavioral component, which likely contributes to the rapid weight regain. Listen, physicians want to help, but they lack the practical means to implement and sustain an exercise and weight loss program in a community-based environment. So the policy relevant and clinically significant question is, how can we adapt these successful weight loss methods to provide a cost-effective intervention for real-world clinical and community settings? The CDC has published 4 strategies to meet the chronic disease burden. And one of those is the establishment of community conditions to support healthy behaviors. And so what we are suggesting is a path forward. And I have a little video that suggests how to go about doing this on a large scale.
I've been on every diet, honestly, known to man. I've been on Weight Watchers, I've done Jenny Craig, I've done some crazy thing where I put drops in my mouth, and I mean, I've tried everything, and sometimes we do it together, sometimes it's just me, but it's never been sustainable. I'm very successful at losing weight. I always have been successful at losing weight. I'm not successful at keeping it off.
I didn't have the motivation. I knew I was gaining weight. I kept having to buy bigger clothes, and I got to a point where I don't want to do this anymore. I don't want to keep going up and up, and my husband was constantly mentioning my weight, and that was making me angry at myself because I wasn't doing anything about it. Now that I've learned things about where I should be, what my weight should be, I was actually obese. I had never used that term about myself before, but my doctors never told me that I was overweight or anything, so I felt like, oh, I'm fine.
I actually have a family history of osteoarthritis. My dad had 6 hip replacements. He had inherited a bone disease, and my mother had a knee replacement, and so I started having some hip pain, and they diagnosed a little bit of osteoarthritis or degenerative bone in my hip, and he said, you know what, diet and exercise, and he sent me on my way, and you just are on this constant cycle. And it's so defeating, it really is.
That's really the key to long-term and successful behavior change. Building confidence, having compassion, being together on the journey toward their weight loss versus just a prescription that we're writing saying, actually, you need to lose weight and exercise. Good luck, go do that on your own. That's probably what they've been told many times.
And that's really powerful when you bring a community of women together like that and watch them help each other, because they love the accountability of seeing someone else that come together on the same day and go exercise together. And we're up on the machines and we're strengthening and we're encouraging each other, because diet without the strengthening, you know, without the exercise is not sustainable. It's maybe not inevitable that I'm gonna have hip replacements and knee replacements like my parents. I'm actually gonna be able to prevent it. That's my hope.
So I've come to think of the GLP-1s as something that we can use for those women together with the behavioral training, with the exercise and with the diet as part of our toolbox, because I think they can become very useful as a jump start or as a tool along the path that, coupled with, and that's the most important part though, from me as a behavioral psychologist, coupled with understanding the behaviors that go along with maintaining that weight loss through diet, maintaining lean mass through exercise.
It's becoming a habit, finally, which I never thought would happen either.
I feel like it's sticking in with them and it's sticking with me, and it's, I don't know, I'm very hopeful. I really am.
So what does that path forward look like to us? Well, there are 4 points. The first is healthcare insurers need to take an active role in developing and funding community programs with trained staff skilled in behavioral techniques. These community programs should be based on empirical data from high-quality diet and exercise randomized clinical trials. Each interventionist has a behavioral toolbox that could include GLP-1 as an option, as Dr. Mahalko had said in that video. And then finally, accountability is achieved by sharing patient progress with the healthcare provider at regular intervals. Thank you very much.
Thank you so much, Dr. Messier, for sharing your expertise with us. I think you made quite a compelling argument for the benefits of diet and exercise, both for prevention and management of osteoarthritis. Feel free, those of you in attendance, feel free to type any questions you have for Dr. Messier in the chat, and I will read them aloud. We have time for just a couple of questions today. One question I had for you, Dr. Messier, just to get things started is, I know that many of the studies you described have pretty intense intervention components and support as well. So what would you say to a person, and again, I know you've talked about kind of a need for these programs to be developed, but in today's current environment, what would you say to the person with or without osteoarthritis who wants to embark on these diet and exercise efforts, but maybe doesn't have access to your studies or to these programs yet?
Sure, that's a great question. We have done, in fact, UNC was part of this, the WeCan trial, which was a pragmatic trial. So we did almost no testing at all. We took pretty much all comers into the study, and we got very similar results as we did with more intense intervention, which was the IDEA intervention. And so we can do this in community-based environments. But really, I mean, what third-party payers want to know is what they like to see is empirical data that actually proves that something actually works. And we have that. We have, 3 decades of that. It's not just us. There's a number of other study groups that have shown the effectiveness of diet and exercise. And then to really get this, I guess the next, somebody asked, well, what's going to be your next study? Well, I guess the next thing we really need to do is it's called implementation science, to implement what we know works into a healthcare system, right? And to have it be part of somebody's healthcare and on a regular basis. So I think that's where we need to go with this, and you need to hire the right people and have the right interventions that have been proven to be effective. And if we do that, then, my feeling is you go to the doctor and the doctor says, well, you need to lose weight and you should exercise, go see my PA. The PA says, well, here's 3 or 4 different places in the community that we know that have been approved. You should join one of these, and then we'll get feedback from them every 3 or 6 months to see how you're doing. And then it becomes part of your lifestyle. And part of it is being supplemented by your healthcare insurance, because it's going to be better for the insurance companies in the end, because they're going to have less severe diseases, less knee replacements, those kinds of things. So that's our vision of how this would work.
It's exciting to hear that. And we do have, this is a hot topic, as you know. We have a couple more questions in the Dr. Messier. Yeah.
Yeah, I
Okay.
got you.
Great, thank you. So quick question I think you can answer, is avoidance or delay of total knee replacement one of the outcomes you are monitoring?
Our major outcome for TOPS would be whether you get osteoarthritis or not. So that's why the intervention is 4 years, because osteoarthritis takes time to develop. So in the beginning, everyone has no osteoarthritis in at least one knee by X-ray and by MRI. And then after 4 years, what we're suggesting is what we're implying is that the group with diet and exercise that has lost the weight and kept it off for 4 years, fewer of them will develop knee osteoarthritis compared to to the control group. So that's the main outcome, is whether you have OA or not.
Okay, great. Thank you. And another question, what is the efficacy of behavioral interventions for preventing the return of weight post GLP-1 withdrawal?
Yeah, we don't know that, right? Right. I mean, that study hasn't been done. And it needs to be done, because right now we know that if you just, once you stop the GLP-1, if you don't do anything else, then you're going to regain all that weight in a little more than a year. And so you may be worse off than you were before you started. Now, that's not to say that weight loss isn't, I mean, if someone has a cardiovascular disease, and they're in real danger, the weight loss can really help. I mean, there's been a number of studies. These GLP-1 studies have shown the risk factors, cardiovascular risk factors, and a lot of other things really improve over the time while you're losing the weight. The problem is what happens after the intervention is done. Or do you need to take the GLP-1s for the rest of your life? And one physician I talked to said, we take a lot of things for the rest of our lives. Maybe this is just one of them. So that's one way to doing it. But, but it's not a lifestyle change, right? It's just taking an injection. We want people to enjoy food. We want food to be part of their life, where they can really enjoy. I know when my wife and I go on vacation, a big part of it is food. And so not having that ability to enjoy it, or always watching out for that, there's something not right with that, and so we just think eating healthy, making it part of your lifestyle you're much better off in the long run.
And this last question kind of is a great segue. It's also such a testament to your work, Dr. Messier. So the comment and question are, inspired by Professor Messier, I have adopted a diet and exercise program, reduced my body weight by 15%, and had quite an amazing reduction in pain and increase in quality of life. My question is, what behavioral practices have you found helpful in maintaining a healthy weight? I'm assuming after the initial weight loss. What are maybe some practical tips for that maintenance part?
Well, first of all, I want to thank whoever wrote that. That's very nice. The check will be in the mail. But usually, so what happens after you've done this person's self-efficacy is probably really increased, right? They have confidence. But confidence in losing the weight is different than confidence in being able to maintain the weight loss, right? And so that's part of the study, because it's 4 years. We expect to have them have lost the majority of their weight within the first year, and then for 3 years to maintain that weight loss. That is no easy task, right? And no one's really done that yet. So I guess the long answer is that we haven't really shown that we can do this for a long period of time, but there's got to be a psychosocial part of this as well. I mean, there's got to be an increase in self-efficacy, a feeling, a confidence that you can do this, that you have a support group, and so that is part of what the psychosocial part, the psychological part of our interventions is very important.
That's wonderful. And thank you again, Dr. Messier, for sharing this presentation with us and spending this time with us to answer these questions. We are very appreciative. For those of you in attendance, we will, and just to follow up, Dr. Messier, the commenter said, thank you. When I work it out, I'll tell you. So thank you to everybody who joined the presentation today and contributed to this very rich conversation. Dr. Messier, thank you again. Just want to mention that we will have another webinar on February 19th, and that is titled Rethink Osteoarthritis, How Digital Mindset Interventions Improve Physical Activity Engagement and Empower Knee Osteoarthritis Management, featuring Dr. Melissa Boswell. Thank you so much for joining us today, and that concludes our presentation. Have a wonderful rest of your day.